members and the audience who have joined virtually and at 10 locations at live webcast locations. I'm Dr. Ankush Gaikwad and I welcome you to this today's No Thrombosis workshop. I'm very happy to announce that today is the 75th edition of this No Thrombosis workshop. So in No Thrombosis workshop, basically we focus on discussing interesting and unique stroke cases and brainstorming discussions with the help of all faculty and experts. Today's 75th No Thrombosis workshop actually coincides with our approval for an extended treatment window period of 4.5 hours from symptom onset. So it's my pleasure from Genova and Emcure to announce that Tenictase is now officially approved from regulatory authorities. And on the right hand side, I have also inserted a pack insert where the updated prescribing information of Tenictase, which mentions in the red colored arrow that it can be given as soon as up to 4.5 hours of stroke onset, is officially now mentioned in the packaging insert of Tenictase. So with this important update, I would like to welcome faculty for today's meeting and would start with our host directors, doctors. I would keep the introduction short. We have a galaxy of experts today in this wonderful meeting from across India, and we have great wealth of experts today here. So just to introduce our host directors for today, Dr. Subhash Kaul sir, who is a senior consultant and stroke specialist at KIMS Center at Secunderabad, Dr. N.R. Ichapuria sir, Director Neurology at Sayadri Hospitals, Pune, and Dr. K. Ashokan sir, Chief Neurologist at and Head of Neurosciences at Sri Krishna Hospital, Coimbatore. So I welcome all the post directors to this workshop, and I specifically want to thank all our post directors, Dr. Ashokan sir, Dr. Ichapuria sir, and Dr. Subhash Kaul sir, for their energy and enthusiasm in driving the workshop over last 1 year. Because of their persistent and interest and attention in this workshop, this no thrombosis events has been extremely successful event and consistently seen large number of audience over last more than 1 year. So thank you, sir, all of you for driving this workshop for no thrombosis workshop and making this event successful. Being and now we are ultimately putting up this 75th event for no thrombosis. So thank you very much, sir. And I will pleased to introduce our moderator for today's workshop, Dr. M.V. Padma Srivastava, ma'am. Ma'am is the professor, head of the Department of Neurology and Chief of Neurosciences at AIMS, New Delhi. Ma'am was a former president of Indian Stroke Association, has more than 200 publications and awarded Padma Shri by President of India, and a task force member of various societies and instrumental in forming Indian guidelines. So thank you so much, ma'am, for joining today and accepting our invite for moderating the panel discussion and the entire session. And I would like to introduce our first speaker for today, Dr. M. Pradeep, sir. Sir is a chief neurologist at UMED Super Specialty Hospital, Kerala, and head of the Department of Stroke and Neurosonology at KG Hospital Postgraduate Institute, Coimbatore, India. Sir has been ambassador for India for European Society of Neurosonology and Cerebral Hemodynamics and postgraduate teacher since 1998. And specifically, I would like to mention that Dr. M. Pradeep is involved in original research work of tenecteplase in AIS and the Genoma trial, which led to the approval for tenecteplase in India. So thank you so much, sir, for accepting invite to be the speaker. I would now like to welcome our esteemed panelist for today, Dr. Shailaja ma'am. Ma'am is a professor and head of neurology at Sri Chitra Trivandrum. Ma'am has more than 180 publications and 14 book chapters to her credit. Ma'am was a past president of Indian Stroke Association and task force member at various societies and organizations. I would also like to remember Dr. Arvind Sharma sir, head of neurology at Zydus Hospitals. Sir is the current secretary of Indian Stroke Association and president of National Board Accreditation Gujarat and founding member for Society of Neurosonology. Our other panel members include Dr. Jayanta Roy. Sir is a director at Stroke Program and senior consultant Department of Neurology at Kolkata and certified sonologist and has over 36 publications to his credit. I would also like to welcome Dr. S. Meenakshi Sundaram, sir, who is a senior consultant at Apollo Hospitals, Madurai, and has over 20 years of experience in neurology and has been a principal investigator in various trials. So now I would like to hand over to our course directors uh, to comment on this journey of no thrombosis. So I would like to hand over to Dr. Subhash Kaul sir, followed by Dr. Ichapuria sir and Dr. K. Ashokan sir, just to enumerate, say words on this important journey of no thrombosis, and then I would like to ask Dr. Subhash Kaul sir to hand over to Dr. M. Pradeep sir, and followed by Dr. Padma ma'am for the panel discussion. So over to all course directors for their words on this journey for no thrombosis.
Okay, thank you, Ankush. Am I audible? Can you hear me?
Yes.
Yeah. Okay, so I guess that I'll speak first and then Dr. Ichapuria and Dr. Ashokan in that order, as you have said. And I think this is a Diamond Jubilee workshop today. You know, the Diamond Jubilee word comes from the cinema world. And whenever there's any movie which is Diamond Jubilee, these days we hardly have Diamond Jubilee movies. But previously, when we had Diamond Jubilee movies, there used to be big attractions. And on that day, there used to be a big, all the stars used to be called and invited, and it would be a star-studded program. I myself attended some Diamond Jubilee movies events. And, today it's just like that. All the stars of stroke I'm seeing in front of me. I mean, this is absolutely energy-packed, talent-packed, experience-packed program. I have not seen more powerful stroke program than this in my whole life. And it has been fun attending this program. And as a course director, one of the jobs of course director is to correct the course if it goes haywire. And one of the inadvertent mistakes which you have done, Ankush, is that about Padma's credentials. Whatever you said, that's all correct, but you have not told her latest designation. She is now chairperson of neurology, director of neurology in Paris Hospital, Gurugram, and I think now this is her second innings, and we wish her best in the second innings, and I'm sure she will do very well, and she will be a star in this also, as she was a star in All India Institute. So with that, I hand over to Dr. Ichapuria for his short comments.
Yeah, after Subhash's eloquence, there is very little for me to say. But what I would like to say is, this no thrombosis workshop has been amazing. And at least I've learned a lot of things. And we've seen some fantastic cases presented by very young, aspiring stroke specialists. And some of the cases have been really outstanding. And, we've had discussions going late into the night. It's supposed to end at 9:30, but it goes on till 10 o'clock almost. And it never seems to stop. And there are questions after questions. And I'm sure today will be, as Subhash said, a Diamond Jubilee. So be prepared for lots of questions, lots of discussions. And I'm sure it's going to go deep into the night. So be prepared and for a feast of academic activity. Dr. Ashokan?
Yes, sir. Thank you, sir. Thank you, both Professor Kaul and Professor Ichapuria. As told by you, this program is going on for the past 3 years, not only 3 years, every month, continuously. And we had a very good and a very useful presentation from learned speakers across India. And we were fortunate enough to have healthy and meaningful interactions and comments and cases discussed every time. We learned many new things after these discussions. Today, we have stalwarts in stroke neurology as moderator and panelists as well as chairpersons. So definitely it's going to be an academic feast. Hope all of us are benefited by such meetings and take this to bedside. Thank you.
Thank you very much, sir. Dr. Subhash Kaul sir, may I ask you to introduce our first speaker, Dr. M. Pradeep?
Yeah, may I hand over to Dr. M. Pradeep to carry on the proceedings further? Dr. Pradeep is known to everyone. Are you going to show his slide or that's not required? Everybody knows Dr. Pradeep. He doesn't need any introduction. He is the president of the Indian Stroke Association.
No, it's already shown, Subhash.
Oh, okay, it's already shown. Okay.
Yeah.
Sorry. Yeah. So, Dr. Pradeep, please, I think one of the most important things about Dr. Pradeep is, which some of you may not be knowing, is that Dr. Pradeep has been the earliest champions of tenectic place. And he was a champion of tenectic place when the whole world was against it. Many of us were very doubtful about it. But he stood like a rock and he said no, he had full trust in it, and that trust has been vindicated and proved, and he was proved right. He's a very brilliant neurologist, and he is excellent in other than neurology, other than tenectic place. He's also an eminent neurosonographer. He just plays with the vessels, very well qualified, well experienced, and a very good friend. Over to you, Dr. Pradeep.
Yeah, good evening, everybody. Am I audible?
Yes, sir.
Okay.
Yes, sir.
So it is a real pleasure to be here today evening with all these stalwarts in the field of stroke from the country, and all my respects to all my seniors in the profession, and to my dear friends and all the people who are going to present the cases. Can I have my first slide, please?
Please enable participant screen sharing for me. RX events.
Hello.
Yes, sir.
Can you enable screen sharing for me?
Screen sharing, sir, is already enabled for everything. I think Dr. M. Pradeep is sharing screen right now.
So okay. Dr. Empradeep sir, yeah, now I can. Yes.
Can you?
Yes. One second, sir.
Yeah. So today I'm going to talk on the recent advances in stroke thrombolysis with emphasis on tenecteplase. Next, please. Yeah. See, these are the facts, the World's WHO Global Stroke Fact Sheet 2022. What is highlighted here is stroke is no longer a disease of the elderly, which we were thinking about. Before, we used to consider stroke as a disease of the elderly. But now in 2019, it is found that 63% of the stroke happened in people younger than 70 years old. So that is something really alarming. There are so many reasons for that. And 89% of the global stroke deaths and disability combined reside in low to middle income countries. That is again very alarming fact. Next, please. So, what is the statistics actually? More than 12.2 million new strokes are reported each year, and over 1.1 million people currently living have experienced a stroke. One stroke case every 40 seconds, one stroke death every 4 minutes. Unfortunately, many people present late because they don't recognize the signs and symptoms of stroke. Next. This is the conventional, say how much is the door to needle time. The shorter the door to needle time, the better is the prognosis. This is a very well-known fact. And our entire approach now is to shorten the door to needle time as far as the stroke management is concerned, is the acute ischemic stroke. Next. Now, there has been debate with which molecule is better, whether the alteplase or tenecteplase. And when this journey was started, as Professor Subhash Kaul was mentioning, when I was vouching for tenecteplase, the resistance was very stiff because the data was not that much there. And the points on which I was always highlighting was this particular slide, actually. The excellent fibrin specificity of tenecteplase is almost 15 times more fibrin specific. And what does that mean? Which means the drug which we deliver is delivered to the area where it is supposed to act, with an increased thrombolytic potency and very favorably increased resistance to plasminogen PI1, that is plasminogen activator inhibitor, which means this drug is not destroyed by the plasminogen activator inhibitor, and it has got a longer half-life when compared to your altiplase. So all these are very favorable for acute stroke management. And the dosage, as all of you know, vis-a-vis, it is 0.2 to 0.25 milligram per kg body weight as far as tenecteplase is concerned, as opposed to 0.9 milligram per kg for altiplase. Next. Why tenecteplase? We can administer it pretty fast, no requirement of a second intravenous infusion, shorter time of interfacility transfer. So, apart from all these things, as far as I would say, as far as a country like India is concerned, it was a cost factor that was preventing most of us from using thrombolytic. Even the patient comes during the window period. That was the thing which we were facing when we started our career. A lot of patients, the percentage of thrombolysis was very much low at that point of time because of the prohibitively increasing cost of thrombolysis. And you know the statistics, how many thrombolysis was happening in the country at that particular time, almost 10, 15, 20 years before, even though deserving patients were not able to afford the treatment. So that was the biggest impediment for thrombolysis. Even though the patient comes in time, your hands are tied. So that way, this is a great relief for all of us. And then comes the safety part of this molecule, because even if something is less costly, that doesn't mean it should be used unless it is efficacious and it is safe. So that was another most important thing which decided which molecule to be used. Next slide, please. So that was a journey of tenecteplase which we went through. No, this was in 2000. It started in US with the Haley et al. Trial, but subsequently it failed. It did not take off. Then came the Mark Parsons trial, which showed that, 0.25 milligram per kg body weight of tenecteplase was really efficacious in acute ischemic stroke management and was actually superior to altiplase. Then came the rest of the studies, including the NORTEST. Then came the Extend-IA TNK trial. That was a landmark trial that actually paved the way for tenecteplase. Actually, we all know that was a turning point as far as the tenecteplase is concerned, which clearly showed that intra-arterial for procedures, when it was a randomized controlled trial for 101 patients on each arm. And what was found that those patients who were put on tenecteplase, almost double was the recanalization which was seen when angiogram was done for doing the procedure. Almost nearly double the patients did not require any further interventional procedure. Then came the Geneva, the trial, and of course we got the approval for DCGA approval, and we started using it, and still with a lot of resistance. Since we were among the initial people to use it, phase 3 trial, and we were using it, but rest of the world, they were waiting for it for subsequent trials. Then came the Extend-IA TNK2 RCT. Then that also showed that this is very efficacious. Then came actually the ACT trial from Canada that really gave the impetus for the usage of tenecteplase across the globe. Then came the TASTE and TETRIS trial and TRACE2 trial. All these things paved the way for tenecteplase getting into the various guidelines of management of the US, European guidelines, as well as the Indian stroke guidelines. Next slide, please. Key evidence with tenecteplase. Next. So this was one of the big trials, Canadian trial. We all know, we have all listened to the Vijay Menon when he came to India from the horse's mouth itself. This was for 1,600 patients, and tenth place was 816, altiplace was 784. Primary outcome was a proportion of patients who had an MRS score of 0 to 1. That is almost a total recovery at 90 days after treatment. Next slide, please. And what was the result? Given the ease of use of tenecteplase versus altiplase, results from the ACG trial and compared with evidence to date provide a compelling rationale to switch the global standard of thrombolysis to tenecteplase at a dosage of 0.25 milligram per kg in patients with acute ischemic stroke who present within 4.5 hours of symptom onset. So that was a great relief for all of us. Next slide, please. Now came the TRACE-2 trial, the Chinese one, which again, for 1,430 patients, and the primary efficacy outcome was a proportion of patients who had an MRS score of 0 to 1, which indicated an excellent functional outcome at 90 days. Next slide. And what did it show? TRACE-2 study. Conclusion was tenecteplase was not inferior to antiplase in people with ischemic stroke who are eligible for standard IV thrombolytic, but ineligible for a refused endovascular procedure. Next slide, please. So then came the ATTEST-2, which investigated whether tenecteplase 0.25 mg per kg was non-inferior or superior to altiplase among thrombolysis eligible patients within 4.5 hours of onset. Next slide. What were the results? Next slide, please. So, which clearly showed that MRS at 90 days, tenecteplase was actually not inferior to altiplase. Next, please. And the secondary outcome was MRS of the excellent recovery. Here also, if you look at the odds ratio, it was 1.05. And as far as the non-inferiority, it is clearly non-inferior, whereas the superiority was considered, the p-value is 0.415. Next. Safety outcome. See, there is no significant safety concern as far as tenecteplase is concerned. Next slide. So to conclude, tenecteplase 0.25 milligram was non-inferior to altiplase in acute ischemic stroke, less than 4.5 hours after onset. Superiority test was not significant. 90 days MRS favored tenecteplase. No significant safety differences. Next slide. So again, as I told, ATTEST-2 demonstrated non-inferiority of tenecteplase, re-emphasizing the results of ACG Canadian trial. So these three large clinical trials now strongly establish tenecteplase as treatment of choice in acute ischemic stroke. Next slide. Now coming to this is a confidential data on file, Indian registry in ischemic stroke with tenecteplase, IRIS TNK post-marketing surveillance study. Next slide. Objective of the study was the aim for IRIS to evaluate whether routine use of IV tenecteplase within 4.5 hours of onset of stroke symptom is safe, that is a primary endpoint, that is beneficial, that is a secondary endpoint. It's an open label, prospective, multicentric, non-randomized, but it is an observational study. Patients satisfying the criteria for thrombolysis were followed up for 3 months post-thrombolysis. The dosage was 0.2 milligram per kilogram, single IV bolus administered as a bolus. Primary safety outcome, symptomatic ICH within 36 hours after the onset of thrombolysis. Secondary was our efficacy was MRS score and NIHS improvement. More than 4 points at 24 hours, more than 8 points at 24 hours for 7 days. Next slide, please. So, the symptomatic ICH and mortality. See, if you look at the active PMS Indian study, the symptomatic ICH there were 1,015 patients, was only in 0.6% of patients. As against altiplase, all of you know, the STARS, which is the US study, was 3.3 cases, which is the Canadian study, which is 4.6. SITS most, European, which is 4.6%, and the SITS new, which 5.6%. So which clearly indicates that tenecteplase is by no means not only not inferior, as with superior as far as symptomatic ICH is concerned. With the death at 3 months is 1%. The bleeding events, asymptomatic ICH was seen in 1.3%. Next slide, please. Improvement in NIH stroke scale score, 24 hours, it was seen in 34.4%. As of day 7, it was seen in 56.3%. Now, as far as more than 8 points reduction in the NIH stroke scale score, 24 hours, it was seen in 14.4% versus 26.6% at day 7. Next. So, excellent outcome, MRS score. If you look at the top one is the IRIS TNK at day 7. MRS 0 to 1 is marked green, as well as the MRS 2 to 3 is in orange. If you look at the top bar, you know that excellent outcome is seen with the TNK TPA as day 7 as well as day 90 when compared to the SITS new, SITS most of the cases study. Next slide, please. So, our IRIS TNK, IRIS Indian, this thing, post-marketing surveillance has clearly shown that this is not only effective, but it is very safe drug to be used in acute ischemic stroke. Now, these are the various other studies, systemic review and meta-analysis, which showed tenecteplase is associated with better early neurological involvement, recanalization of blood vessels, and neurological recovery at 90 days than alteplase. There is no significant difference in terms of safety. As a new generation of thrombolytic drug, tenecteplase convenient administration and superior pharmacological characteristics make it promising first-line thrombolytic drug. Next slide. So this is another study. Intra-arterial tenecteplase is safe. This is one of the Chinese study and may improve the first pass recanalization. See, it is well known. If you remove the clot first pass, the chances of the recovery chance is much better. But it is not always the case. Always we may not be able to remove the thrombus by first pass. We may have to do multiple passes. It has been shown that intra-arterial TNK, that is 4 milligram, given intra-arterially, just before your first pass, improves the chances of first pass recanalization. Next slide, please. So, this is an intravenous tenecteplase for acute ischemic stroke within 4.5 to 24 hours. Next slide, please. Next. So these are the number of studies which we now have is tremendous. Safety and efficacy of tenecteplase compared with alteplase in patients with large vessel occlusion stroke. A pre-specified secondary analysis of the ACT randomized clinical trial. What does it conclude? Tenecteplase confirmed similar reperfusion safety and functional outcome compared to alteplase among patients with large vessel occlusion stroke. Next slide. So this is another efficacy and safety of tenecteplase in comparison to alteplase in acute ischemic stroke. Systematic review and meta-analysis randomized controlled trial. Tenecteplase has similar efficacy and safety to alteplase with a more promising effect in patients with large vessel occlusion. Next. Next slide, please. Next slide. Next. Next. So now coming to what has all these things resulted in? This is the American Heart Association and Stroke Association 2019 guidelines. That is it may be reasonable to choose tenecteplase 0.25 mg per kg over IV alteplase in patients with without contraindications for IV thrombolysis or eligible to undergo mechanical thrombectomy. 2B, level of evidence is PR. Next slide, please. Canadian Stroke Guideline. All eligible patients with disabling ischemic stroke who can receive intravenous thrombolysis with either alteplase or tenecteplase within 4.5 hours of stroke symptom onset, last known well time, should be offered intravenous thrombolysis. Strong recommendation, high quality of evidence. Next slide. ESO. Expedited recommendation on tenecteplase for acute ischemic stroke. Next. For patients with acute ischemic stroke, less than 4.5 hours duration, who are eligible for IV thrombolysis, tenecteplase 0.25 milligram can be used as a safe and effective alternative to alteplase 0.9 milligram per kg. Quality of evidence moderate, strength of recommendation strong. Next slide. Facility of pre-hospital management with a mobile stroke unit available, tenecteplase is preferred. You all know why. Patients with acute ischemic stroke of less than 4.5 hours duration with pre-hospital management with a mobile stroke unit who are eligible for IV thrombolysis, we suggest tenecteplase 0.25 milligram per kg over alteplase to increase the rate of early reperfusion and shorten the time from imaging to treatment initiation. Next slide, please. Large vessel occlusion, tenecteplase preferred. For patients with large vessel occlusion, acute ischemic stroke, less than 4.5 hours duration, for eligible for IV thrombolysis, we recommend tenecteplase over alteplase. Intravenous thrombolysis should not delay mechanical thrombectomy, and strength of recommendation is strong, quality of evidence is moderate. Next slide. For acute ischemic stroke on awakening from sleep, acute ischemic stroke of unknown onset, all module working group members suggest that tenecteplase could be a reasonable alternative to alteplase. Patients with acute ischemic stroke on awakening from sleep or acute ischemic stroke of unknown onset and who are eligible for IV thrombolysis after selection with advanced imaging. What is meant is a flare diffusion mismatch. Next slide. Conclusion. Tenecteplase can now be considered standard of care for acute ischemic stroke. Next slide. Thank you very much.
Can I take over?
Yeah, Dr. Padma. Yeah, please take over.
Thank you. Thank you for the kind invite. It's an honor to be here. And I think that was an exemplary talk by Professor Pradeep. It was truly a great summary of the entire trajectory of what tenecteplase has been in the universe, especially in this country. Actually, I think there are two things which make this decade truly special, and I think that needs to be mentioned in the 75th anniversary of the great meeting that you're having now. One, that we have this great lytic drug, and India was the first country to approve, as you already heard. And the second is we also have the Make in India, which also is now proven to be really the standard of care. So there are two ways, like it's a I would say a double trophy in this era for India, because in two fronts it has actually been at the forefront of the entire stroke movement for the world, and not just in the country. So I think it's exemplary. Said that, I think now it's time for the panel discussion, and we have 5 iconic panelists, and I'm also going to include the 3 course directors, and you heard enough about all of them. So the first question, because I think we are running short of time, we've already passed 9 o'clock. So the first question to you, Dr. Shailja, will be, I always pick on you. So the first question to you is, you've been, again, heading the stroke movement. So strokes happen everywhere, not just in Trivandrum or Delhi. They're happening in Timbuktu and at all corners and at all times. And you know that the thrombolysis rate has not really been that good. And that is true for the whole world, I guess. But at your center and any other tertiary cells, probably you cross 10-11%, maybe. But there are centers who've never thrombolized, and still at this point of time in the country, there are situations, even with a CT available, even with a lytic available, they don't thrombolize. So can you list in the 5 prominent reasons why an acute, even intravenous thrombolysis does not happen in the clinical, delivery points in the country? what are the 5 main reasons?
Thank you, Padma. And first of all, thanks to the Tenectes team for this invite to this very important meeting today, which is the 75th webinar series which you're having for the thrombolysis. Coming to what Padma has mentioned, as we all know, if you look at the Indian scenario and when we had done that Indo-US study also where 5 comprehensive stroke centers were involved, we found that the thrombolysis rate even in those comprehensive centers were also less than 5%. So overall, the thrombolysis rate is very low. If you look at the reasons, we can say the first and foremost reason is because the awareness among the patients with regard to the availability of the treatment and the importance of time is still very poor, and the patients do not reach on time. That is one of the first and foremost reason for the patients not receiving thrombolysis. Second important reason is that the patients do not reach the right hospital. Most of the patients first go to a primary care center or a center where CT scan facilities are not available, or to centers where the patients may be referred to a scan center where the scan is being done and then the patient is taken. By the time you miss the time to treat the patient. So that is the second reason. So the patient may first reach a small center and then by the time the patient reaches a center where the facility is available, it is too late for the patient. Third is the patient still we do not know what are stroke ready regard to where the patient should go, and we have certification of stroke centers which is happening now, especially with the Indian Stroke Association and the World Stroke Organization going to start the certification program. That is definitely going to make a big difference, so that just like trauma, we will be able to tell these are stroke ready centers or stroke accreditation is available, so that the public will know these are the centers they should go for thrombolysis. So this, I would say, is the third reason. Fourth is still, most of the strokes are not treated by neurologists. It is mostly treated by physicians. So the belief of still that thrombolytic drug or the thrombolysis is a very effective treatment, we are still a long way to go. I don't think that people still believe this is a very effective treatment and we need to give this treatment to really make a difference for these patients' management. And most of the people still are worried about the bleed risk, even though we know that the bleed risk is relatively very low compared to this being a very effective treatment. I think these are the points which I feel are most relevant to India. Thank you.
Would you think that cost factor would still be the fifth one? Would the expenses be still, in spite of all notifications by the government that everything is going down free, but at when you come down to the ground level, expenses would still be an issue?
No, but if it was like 2 years before, I would have told that cost is a major factor. But now currently all the government hospitals where the poor patients are going, in all the hospitals now, the thrombolytic drug is free. And in the Ayushman Bharat package also, both the drugs are available. So currently, cost may not be an important factor because mechanical thrombectomy, definitely endovascular thrombectomy may still be a factor. Cost may be a reason why the patients may not be receiving it. But for thrombolysis, I would say that comes much lower down because of the free availability of the drug now and being involved in the universal healthcare package.
Great. So if we should say that if people came more readily in time to the right hospital, and we have a map of the right hospitals by due accreditation process, and we have stroke maps which are available in each state, and the more resourceful emergency physicians who would come into the ambit of the stroke care package in delivery, then and we have a Lytic right now, which definitely even in private sectors, maybe where Ayushman is not a part of, you have a cheaper Lytic available. Then at least the intravenous thrombolysis part may become much more available, accessible, affordable, and therefore be there on the trajectory, and we will have more numbers. Okay.
fully
you agree with me?
Yes, I think I fully agree, because still, even though we have all the government hospitals, if you look at most of the studies, and even recently, which a study which we looked at into the rural health blocks, we found that 65% of the patients with acute stroke initially went to a private hospital. So what you told is right. So in these patients, even though they go to a private hospital, they need not be the really affordable patients. So still the cost is an important factor, I would agree. And one more thing I would say, which I missed out, is the lack of availability of the EMS services. Like, we don't have a very good EMS service available, whereby the ambulance will be able to take the patients to the right hospital for treatment. So that is also an important factor if you consider India as a whole.
Thank you so much. Now, can I come to Jayanta? So, if I may ask you,
Yes.
You heard so much. Dr. Pradeep has, beautifully summarized the entire thing. I know that tapestry that he's just started off with 2009 and up to 2023. But you think we have now adequate points all covered for the use of tenectic plays across all scenarios in the stroke management in an acute stroke, in whatever way, or whichever way you may look at it? Wake up and extended time intervals, minor strokes, major strokes, you have large vessels, small vessels, what have you, and the time window frames, or do you think you still need certain points where the tenectic play still has to get ground, basically in accumulating more evidence as compared to the older lytic drug? Or you think we have now enough ground to say that, yes, these points, we have now evidence, it's equal, in fact, it's better. So what do you think are the plays where tenectic play scores over altiplase? And what are the points where it is equal to altiplase? I can have both the lytic drugs in my hand and I can choose what. And the third is where it still has to gain more ground to get evidence.
Well, I think the tenectic plays has put to enough test through enough trial to give compelling evidence that it is a good treatment, it is equally effective, if not better. Now, I personally, and we all here, I believe, do not have any doubts that it is a serious player, and we can safely use tenectic plays in every situation where we think about thrombolizing a patient, starting from large vessel or without a large vessel occlusions. And from the safety point of view, we also have, good safety data. So I think tenectic plays has almost checked all the boxes now to give us confidence that, yes, it is reliable, effective, and definitely very safe. So I think now what we need maybe some more years to get more experience and data of using it, because altiplase is there for almost 30 years. So tenectic plays has to go through that phase. But initial data are very promising, and we all have probably switched over to tenectic plays in almost all in our practice. So I think we are already there. I just like to mention one point. What Shailaja was telling, I agree to her about these 5 points, but I think there is one single point which needs a jerk from the authority, from the government point of view. We need a campaign telling people that if you have a stroke and if you go to a hospital which is a stroke ready or not ready, I don't know, but there is a treatment, you have your right to get the treatment. So if missing an acute stroke who is eligible for thrombolysis, not giving thrombolysis, you are liable. This is something get into the head of people. Otherwise, having everything ready for the stage, we are still not getting the enough number or enough momentum to get it done. So I think the time is right to move forward. Maybe people like you can convince the authorities to come up with.
Me, I'm not there anymore.
You are everywhere. So it is the time we should tell people that, They should come up with, I never seen any campaign from the government that if you have a stroke, you need a treatment. This is a life-saving treatment in prime time. I've never seen that. Need something from the government side also to let people know.
Yeah, but one thing, Jayanta, they don't talk about heart attacks either. The government doesn't talk
That's
about
right.
MI either.
No, I'm
So
talking about those things as well.
Yeah.
Trauma, heart attack, stroke. They are very.
Yeah. I think that essentially comes out of, again, the insurance policies and the state insurance. We do not have health is a individual state subject. It is not a national one voice and one call, which is the way it is for our country. So there are different nations with different policies. So yes, there should be a clarion call, but that's been. I hope it'll be heard at some point of time. So now, Jayanta, if I have to actually summarize from what you said, so will you agree with me if I say that if I have a large vessel occlusion, I go to tentative place, okay, and if I do have a system where it is a stroke coming within the 4.5 hours, it is across all stroke subtypes, not necessarily large vessel, then I can put my hand on tentative place, and otherwise I go to altiplace. And wherein, like, you have a wake up stroke, I still have a minor stroke, or wherein there is still there is an accrual of evidence, because even the large main trials in the wake up and the minor strokes, some yes, some no. So therein I still need more evidence for both lytics, I must say. That is true even for altiplace. And situations wherein you have these vessel occlusions, but you have aspects which are very low, those are the situations where, and also for the bridge trial, and the evidence is now again growing, and a lot of promise wherein there is an intra-arterial, as Dr. Pradeep has said, where an intra-arterial altiplace really did not add too much to an endovascular technique, where probably tentative place may add on a value, which is promising. So that's the promising field. Would you agree with me on that? Jayanta, you have little choice but to agree with me on it. Otherwise, I'm going to hold you.
Yes, I agree.
Thank you so much. Can I come to you, Dr. Meenakshi? Dr. Meenakshi Sundaram. Hi, there you are. So we come to this, a lot of evidence gaining ground on this aspect of when you have a large vessel occlusion and low aspects. And then you have this interventions coming in, whether you want to bridge them or you directly want to go to an EVT. Would you summarize for us where we are exactly in this part of a LVO with a low aspects? You want to intervene or not?
One of the recent papers, in fact, has talked about the benefits of management even in low aspects. So for me, what we practice is we give the choice to the family. We tell them we are having a difficult situation, but any other thing other than this could be even more disastrous. And we keep giving examples to them. One of the best examples I learned is from my friend Dr. Balmurugan, and that has been very effective when we talk to the patients. He says, you are like a firefighter. If you have your house on fire and the fireman comes, you will tell him save as much as possible. You wouldn't tell him, look, on the third floor of your this one, you have my documents ready, you must get it. On the second floor, I've got my money ready, you should get it. If you can do all these things, I will let you go in. That's not going to happen. You have to just say whatever you want and you have to come out. So I tell them whether you have low aspects or high aspects, whatever you have, we'll try to save, provided you understand the risk and we will take you through. With that, when we tell them, and in fact, most of the times we video record and give it to them, and believe me, they are accepting more often than not. That has been my strategy.
No, excellent. And I think I'm going to, with your permission, I'm going to use what you have said to talk to my patients as well. So that was brilliant. So, but then now we also have more and more aggressive interventionalists who are, with their expertise as well as gadgets, which are proving to be much more maneuverable and safe to be, to go in. And I guess so they are able to do this. So we will wait for more evidence on that. So quickly, I don't see Arvind. Is he there? Dr. Arvind Sharma? So if not, can I go to my favorite course directors, all three of them? In fact, I'd love to put them in a spot. Dr. Kaul, may I start with you? Can you tell me what is your take on the character of a thrombus when and the outcome after intervention, both the length as well as the composition of a clot, and what it would mean to you when you want to choose your thrombolysis, whether it is just an IVT or you want to or an EVT.
No,
Prominently, I would ask for an IVT, the length as well as character.
Yeah, no, I mean, as far as the practice is concerned, I know that there is a lot of literature which say that if you've got a long length of the clot, then they are more likely not to respond to the IV thrombolysis, and even the composition wise also. But the point is that irrespective of the length of the clot, we have got a set protocol. The set protocol is that we give IV thrombolysis in every patient. It's not that I will directly go to the mechanical thrombectomy in people who are having a long clot. I will anyway do the IV thrombolysis, and at present we do tenecteplase, as simple as that, because it is thought to have better from the whatever data it is. And after that, I will most likely go to the mechanical thrombectomy. Now, if it's a small clot, still I will go for tenecteplase. If it is less than 8 millimeters or so, still I will go for tenecteplase. And it's quite likely that it will dissolve it, but sometimes it may not dissolve it. In that case, we'll go ahead with the mechanical thrombectomy. So irrespective of the clot length or clot composition, it is not going to change my protocol. Protocol remains same. IV thrombolysis followed by repeat imaging to see whether it has lysed it or not. In 30%, it would have lysed. In 70%, if they are big clots, it may not have lysed. Then I would go for mechanical thrombectomy. Because at this time, we don't have any such technology by which before thrombolysis, we can know about the clot composition. We know about clot composition only after doing mechanical thrombectomy. And that helps us only in the secondary prevention, to know whether it's a RBC rich clot or whether it's a W. But of course, the length of the clot is important, because if the clot is very long, we should know that most likely you are going to need a mechanical thrombectomy. So that's
Excellent.
how I agree.
Yeah, excellent. As always, there's so much of clarity when you speak. So I guess the knowing the composition of the clot would be helpful in understanding the pathophysiology and designing more ways of approaching it, or LITEX, or even prognosticating and the outcomes. At this point of time, our practice is clear. We stick to what we always do. If I may come to Dr. Ashokan. Sir, are you there? Are you there? Because I'm not seeing your video, so I'm not very sure if you're there. Here. Yes, sir. So if I may come to you, what are the usual causes of the early neurological deterioration that you see in your clinical practice? So far, if you could summarize the three most important reasons that you found in your practice, the common reasons for what we call as early neurological deterioration, in an acute ischemic stroke.
Yeah, the main three things, right? Increase in the volume of the size, infarct size, and edema, peripheral edema, surrounding edema, and hemorrhagic transformation. Plus high BP, uncontrolled, that is another risk factor. High sugar, if not controlled, is another risk factor. And of course, infection. So these are the things which may cause deterioration in the total outcome.
Right. So, but
increase in the volume is the main thing.
Right. So, would you can you list out a couple of points as to why would the volume increase? Say in an acute ischemic event. Say it's a large vessel.
Exactly, ma'am. Because of poor collaterals, distal collaterals, if they are poor, probably they go for increase in the volume. As well as cortical infarcts, where already the collaterals are poor, that will further cause deterioration. So main thing is collaterals.
Right. So it is a co-collateral ratio that you say that, it's a huge because there are poor collaterals, and that's what. Excellent. So I think since you're almost running, and I can see Satyan and the others getting very impatient. So the very last questions, and it is open to all the panelists that, what would one of you can take these questions and summarize, since I don't have time to ask each one of you. What would be your take on managing an acute ischemic event 4.5 to 6 hours, 6 to 16 hours, 16 hours and over? Any one of you, any volunteer can take up on these three. Then we go on to the case discussions. So, Shailja, let me ask you. 4.5,
If
4.5 to 6 hours.
Yes, 4.5 to 6 hours. Currently, if you're talking about if the patient is having a large vessel occlusion, we don't have any doubt. We are going to take the patient if it is between 4.5 hours to 6 hours. If there is a large vessel occlusion, we are going to directly take the patient for a thrombectomy. But if the patient is not having a large vessel occlusion and the patient is within 4.5 to 6 hours without a large vessel occlusion coming with an ischemic stroke, you can do a perfusion imaging in this patient and then decide for intravenous thrombolysis if there is no large vessel occlusion.
Thanks. No, I think I missed out Nashli sir. Dr. Ichapuria, I didn't see your video, so I missed out. I have this question is for you. Tell me your take on 6 to 16 hours and 16 hours and later. There you are. Yes.
Yeah, now you're asking me very difficult questions.
Yeah, I always keep the most difficult for you, and you know that.
Okay. 4.5 to we know.
Yes, that's
yeah.
that. Yeah.
Now, within 9 hours or so, we would do a diffusion, we would do an MRI in this case and see for diffusion-perfusion mismatch. And or we would do a perfusion scan and see if there is a core and there is a penumbra. And if there is, then we could go ahead with IVT or mechanical thrombectomy, depending on the situation. Now, up to 24 hours, the number of patients of this type are very few. And, everyone says, that the number needed to treat is only 2 or 3. But, the numbers are small because there you have to have a small core. So in these type of cases, you need very good imaging. You cannot just do a plain scan or just a CT angio. You need a proper imaging, including a perfusion scan to see the size of the core and to see the size of the penumbra. And if there is a big mismatch, then definitely we would like to go in directly for mechanical thrombectomy. That is, 6 to 24 hours. However, now there are new papers to say that whatever the size of the core, you should go in. But, these type of patients are few, and the benefit that you get with large cores is also very small. So, only about 10 to 15 to 20% will respond and do well. That means get MRS less than 2 with a large core. So this, as SMS has already said, you have to talk to the family. You have to see the family situation, the social situation, the financial situation, and then go ahead with these. If it's a young person and then definitely we would go. But if an 80-year-old comes, maybe we would not. Because, then they get bedridden and they get, their MRSs don't improve. And though they may improve to some extent, they become a burden to the family. So here you need very detailed counseling and case selection. But certainly in a young person, even if the core size is large, we would tend to go in as a rescue. This is a rescue operation. I mean, you are not going to achieve great MRS. You're not going to achieve total independence. So So here the situation is a little difficult. But if the core is small, even at 24 hours or even longer, and sometimes even with basilar artery occlusion, even if it is longer, then we would tend to go in and do mechanical thrombectomy in these patients. However, I must say that I have not been really very impressed. And many of these patients don't do really so well. You know, everyone says that basilar you can do at 24 hours and 48 hours, but my experience has been very poor. I don't know, somewhere we are going wrong or what. I don't know. These patients don't do well. You open up the vessel, but still the fellow does not improve. And the next day you do a scan and there's a huge infarct or there's a hemorrhage. And, you know, there is disappointment, you know, after having spent so much time, money, effort getting the interventionist. You know, it's a big military operation to do intervention. It's not so easy. And sometimes I feel that, you know, in these difficult cases, I mean, the West is going for it hammer and tongs, but in the Indian setting, I find that it's getting a little difficult for us. I don't know what others feel, but this has been my feeling. So, you know, in a good case, yes, dramatic results occur. Dramatic. You know, the fellow's MRS comes to zero, or they walk home and they can do their daily activities. So, yeah. So, as time goes on, it becomes more and more difficult, and the MRS becomes less and less. I mean, worse and worse. So, you have to select the right patient.
Yeah, got it. So, actually, if I may summarize, that we do have, you know, you have the diffuse, you have the other trials of interventional trials, we have evidence till 24 hours, wherein you have carefully chosen patients by whatever criteria which have already been published, you can do it. As the IVT is concerned, we have some of the recent trials with tenective plays, which are up to 24 hours. Again, I guess it's a careful selection, and it cannot be one glove fit all. It cannot be one thing that whoever walks in at 24 hours or who's wheeled in at 24 hours, irrespective of what stroke subtype it is, that you can just go in and push in a lytic or do an endovascular. So it all depends upon a careful selection. And it's always selection and selection and selection to get a better outcome. So that said, but we're probably improving both in our lytics and also in our process of selecting patients. So there are more and more coming under the ambit of the acute stroke treatment. So I think can
I ask one question, Dr. Padma?
To whom?
To all of you, because
okay.
What was the role of tirofiban when there is no large vessel occlusion and, you know, the person has come within, say, 10, 12 hours? Has anyone used it consistently, and what are the results?
Yes,
so
sir.
I know about, yes, sir, please go ahead.
Yeah. Can I answer?
Please.
Yeah.
Regarding tirofiban, so we have used in some of the cases, like where especially anti-circulation strokes, after the first pass opens, reocclusion, second pass, reocclusion, third pass, reocclusion, fourth pass, again reocclusion. Such a situation, no other alternate, we had used tirofiban.
No, I'm talking of IV tirofiban, sir. I'm talking of IV tirofiban.
Oh,
not after intervention, IV.
I'm talking about intraarterial. Okay.
So actually, we have the evidence, as Dr. Ashokan has said, is all for an intervention procedures. Tirofiban has been given along with it as an additional process when they were going and doing an EVT, not as not as an IV lytic. None of these GP2B3A receptor blockers as an IV thing have actually, even starting with abscizumab, they have been probably dismal. So I do not think I have any experience on IV.
I have, Padma, can I come in?
Yes.
I was once reviewing this capsular warning syndrome literature, and I gave a talk also. In that, they have used IV tirofiban in that setting, and there is some data. It has stopped only that particular stroke. When your recurrent TI is in the capsular warning, there tirofiban has been used. But that is just one case series. It's not in guidelines.
You know, there is a Chinese study to show that it's not been replicated. And, you know, everyone says that Chinese studies are not good, but I don't agree. You know, many Chinese studies have stood the test of time. So, and they are really doing great work. So they have shown that when there is no large vessel occlusion and the person has come after 6 hours or so, they have used in some patients IV tirofiban with promising results. I mean, it has to be replicated. So we don't know yet, but I just wanted to know what the general feel is. Dr. Shailaja, have you?
No, sir. Even I have not used it as an IV, but as Dr. Ashokan has mentioned, most of our use is only for reocclusion. We have used Terofan a lot for the endovascular. But as Padma also told, so if you look at the previous apixaban trial also, all those studies have shown an increased bleed risk. So it may be for a select group, as Dr. Kaul has mentioned, is with regard to lacunar warnings type of syndromes or a small core patients, which may be totally different from the other group of larger infarct volume. So maybe we don't know. We need more evidence. We have not used it before.
Excellent. So I think with this, we will probably, if it is okay, Emcure, we'll close the panel and now we get on with the case discussions. So the first case is by Dr. Vishal. Are you here, Dr. Vishal?
Yes, ma'am. Yes.
Yeah. So you would be presenting in 5 minutes your case, and then the case discussion will be taken up by Nashli sir, Dr. Chapuria sir.
Yes, ma'am.
Over to you, Vishal.
Thank you. Okay, I'm sharing the screen. So this is the first case, a 60-year-old lady, known case of diabetes, hypertension, hypothyroid. The onset of symptoms was at 11:30 a.m. She was at home and she felt right-sided weakness, paresthesia. She was unable to coordinate with the right side. She was unable to walk and speak properly. And then she came to our hospital. It was around 12:30 p.m. So after 1 hour, she came to hospital. So it was stroke in window period. On examination, the NHS was 14. She was alert. She was understanding. There was partial wernicke's. The fluency was impaired.
Please, Vishal, can you change your slides and you can put it on the slide mode?
Yes, I'll do that. Just a minute.
Or just change your slides. I've gone to the next.
Visible and I'm audible.
Yes.
Go ahead.
Yeah. So this is a case, a 74-year-old female. She presented with acute onset left-sided hemiparesis with left side facial palsy and dysarthria since 11:45 p.m. on 24th of October. She has a significant past history of hypertension, OSA, hypersensitivity pneumonia, And she also had a history of left MCA territory infarct 2 years ago. Thus, she was already on a single integrated agent, that is ecosapent and atorvastatin, and she was well compliant on that medicine. Significant history was allergic to sulfur drugs. When she had presented, she had a high blood pressure at the time of presentation. Her BP was 200 by 110 millimeters of mercury. Other vitals were okay. RBS was 156, and her NIHS score was 11. I briefly play a video of the patient. The consent has been taken from the patient for video purpose. So clearly, she had a disabling stroke, and she was within window period. So we had to consider her for IV thrombolysis. Now, the next question in my mind was to choose which form of imaging to be going ahead with. Was it a CT scan or an MRI brain? Because of the accelerated blood pressure at her presentation, that is 200, I was a bit concerned about the presence of microbleeds also. And there was a possibility that she also had a history of previous ischemic stroke. So that was also weighing in at the back of my mind. So I wanted to go ahead with the MRI imaging and then consider thrombolysis. So the next is MRI imaging. So she had this is a diffusion scan. It showed a area of diffusion hyperintensity in the right MCA territory, and which was still evolving. It was next up was GRE sequences. So just to make sure about the number of microbleeds, I'll just skip through this because the imaging quality was also degraded, but there were less than 5 microbleeds anyhow in this MRI, that is GRE sequence. So next stop was the flare sequence, although we knew that the patient was within clinical window period. So the presence of the need for IV thrombolysis was already emphasized to the caregivers, and the flare sequences only confirmed the findings that the patient was within window period, that she had uh, the flare negative area corresponding to diffusion hyperintensity. So the next stop was vessels. Angiogram was done. I'll not play the video, but angiogram did not show any major vessel occlusion amenable to mechanical thrombectomy. So the course in view of elevated blood pressure presentation, I had to control the blood pressure first, and that's why I gave her IV labetalol 10 mg, which was repeated. Thereafter, the BP was noted to be 174 by 90, and then the attendants were counseled for IV thrombolysis, its risk and benefits. I did emphasize the slightly increased risk of hemorrhagic conversion because of the presence of an accelerated hypertension at the time of presentation, and that the patient was already on single antiplatelet agent. So there was a delay due to deliberation from attendants, and once the consent was given, again the BP shot up to 190 by 100 millimeters. So another shot of labetalol was repeated, and after the BP was noted to be 180 by 90, she was given thrombolysis with tenecteplase. So why I chose tenecteplase was because of its better safety record. I felt that the patient would merit a molecule which should be safer, which should not produce an ICH, And because of the patient's risk factors, that is the presence of high blood pressure and the single antiplatelet agent, I was concerned about that also. The next question in my mind was to whether go with the conventional dose, which is usually advocated in most of the trials, that is 0.25 mg, or should I go with a slightly smaller dose, that is 0.2 mg per kg. So I chose the later. Why I chose that was again for the reason similar, that the patient had a labile blood pressure, and there was every chance that the patient was going to have an increase in blood pressure during the process of or immediately post thrombolysis also. So I chose the tenecteplase dose of 0.2 mg per kg, and she was thrombolized 4 hours after the onset of symptoms. The door to needle time was prolonged, 1 hour and 45 minutes, but that is because of the MRI imaging which was done, and then there was a accelerated hypertension which had to be controlled, plus some time of discussion to the caregivers also, some time for discussion. So post procedure, she had an improvement in her NHS score to 5, and that is 24 hours after thrombolysis. And on last follow up at 3 weeks, she has had a complete recovery from stroke. So I just give the post procedure CT scan that did not show any major that did not show any hemorrhagic conversion. And this is the last follow up of the patient. The ambulatory without support, the facial palsy has improved. Speech is okay. I'll rush through the slide. She was ambulant without support and going about her activities of daily living. So just a bit about the literature review, as it's all been touched upon. It's only repetitive, although that the relative risk of thrombolysis with tenecteplase and alteplase, relative risk of ICH during thrombolysis with tenecteplase and alteplase is lower for tenecteplase as compared to alteplase when we compare the low dose as well as the mid dose. That is the just use it. That is 0.2 mg per kg, less than 0.2 mg per kg, and 0.2 to 0.39 mg per kg. The rates of ICH are lower for tenecteplase as compared to alteplase. It's only at high dose 0.4 mg, more than 0.4 mg per kg, that alteplase is, that tenecteplase is associated with more hemorrhages. And in patients who have received antiplatelet therapy, who are receiving antiplatelet therapy, the chances of hemorrhagic conversion have also been evaluated in this study, which was published in the esteemed journal Stroke in 2010. And they noticed that the rates of hemorrhage were 4.1% for antiplatelet naive patients. And if the patient was an any antiplatelet agent, the rates were 6.2%, 5.9% for aspirin, and 4.2% for clopidogrel. Whereas if we look at the combination of aspirin and clopidogrel, the rates were 13.4%. So this also calls for caution, especially in those patients who are on dual antiplatelet agents. So this is the approval from the concerned authorities regarding an approval of tenecteplase for ischemic stroke within 4.5 hours of the stroke initiation. So key points, what I would suggest, like to make is that patients with labile accelerated hypertension and currently on single dual antiplatelet agents are at an increased risk for hemorrhage with IV thrombolysis. In these patients, we can use a clinical acumen and offer the patients a lower dose of safer thrombolytic, which is a tenecteplase, and at probably a lower dose, that is 0.2 mg per kg. And these patients should be considered for IV thrombolysis. Thank you. Over to the moderators.
Dr. Ashokan, sir. Dr. Ashokan? Dr. Ashokan, sir, yeah. I think you will be moderating this case.
Yes, yes. Okay, thank you. This is a very good presentation. I agree. Rather, labile hypertension, of course, BP, you have to initially control the BP, and even otherwise, it's approved up to 180, 110. Maybe anything more than 180, 110, you should be very careful. but better bring it down, little down, and labetalol, IV level, using IV labetalol is agreed, totally agreed. But single antiplatelet does not have that risk of, bleeding risk after this thrombolysis. Maybe dual antiplatelets may have that risk. And another thing, even with 0.25, this particular patient are done even better. I don't find any risk of hemorrhage. By having controlled BP, this can be given safely. Thing is, uh, post thrombolysis, and she didn't have any large vessel occlusion. That's another important point. The large vessel occlusion with such a problem, probably you have gone for thrombectomy also. This is only rather very clearly shown there was no large vessel occlusion. And this patient would have done even better with the 0.25. That's what I feel. Anyway, with the 0.2, the clinical outcome was good. No doubt, outcome is very good. And of course, mostly we use only tenecteplase. We are not doing alteplase. We are not giving alteplase nowadays. Yeah, because that you have to give for 1 hour, and BP during the time of infusion might go up, and you have to control it. Yeah, otherwise very well managed. I agree. But a single antiplatelet is not a contraindication or not against any thrombolysis. As you said, dual antiplatelets might increase the risk of hemorrhage. Okay, thank you.
Thank you so much. So I think it's a very nice case, and he's brought out some salient points. And I think I think all of us would agree with Dr. Ashokan sir that we won't be too overtly bothered about aspirin being taken. So that I think that belongs to bygone era where antiplatelets were a huge problem. Now it's not. Even our neurosurgeons don't bother operating on them when they are on those. So that's okay. I think single antiplatelet should not bother too much. And there may be some difference of opinion as regards the imaging. Some would still believe that the workhorse could still be a plain CT scan because she was well within the window period, within an hour on a single antiplatelet. And you can control that blood pressure with labetalol and just go ahead. Rather than, but I can, the world is divided between CT and MR believers, and in acute imaging, there's a lot of clinical practice where it is MR and not a CT. So I'm not going to contest that, but it's just some practice that most of us would use a plain CT as a workhorse, the CT angio rather than get into an MR. But yes, it's a great case, and thank you very much. So if we can go to the next case, and is Vishal, are you ready? Yeah, you're ready?
Yeah,
please go ahead. Yeah.
Madam,
I'll
can I
start
have one
sharing
word
this
there?
screen.
Yeah, please go ahead.
I'm just curious about the cerebral microbleed that was mentioned. So in fact, if you have done the MRI, sometimes it will only confuse. So why bother about microbleeds? Because it's not proved.
No.
Time, as you have mentioned, is
exactly.
So,
Exactly. Now, I think the MR and a microbleed should not enter into a dialogue at all, because that'll only be that'll confuse the picture, Satyan. The microbleeds, they are there listed, and just like an echo and an LV clot, thrombolize and you disperse, and you have microbleeds, big ones, amyloid angiopathy. You're not really, they are there as risk, but every case you don't put it into your protocol because time still remains critical. So I think we should be bringing in microbleeds, and therefore I'll do an MRI to look at microbleeds before I thrombolize, because the patient has a 200 by 100 blood pressure. Probably is not getting into the right dialogue, as I think I would look at it that way. I won't be doing it. I mean, that's what I think Dr. Meenakshi Sundaram is also trying to say, isn't it? That,
yes,
I think we should be bringing that into our dialogue.
So I wouldn't bother about microbleeds at all there.
Yes.
Thank you, Dr. Satyan.
Yeah. Okay, Dr. Vishal, please go ahead.
I'll be sharing the screen now. Okay, so my first case, a 60-year-old lady. Now, as I had already presented, she's a diabetic, hypertension, and hypothyroid. The onset of symptoms was at 11:30 a.m. She was presented at 12:30, and the NHS was 14. She was alert. There was some Wernicke's aphasia. There was impaired fluency, and there was so these are the infarcts we can see here, and this is the angio which is showing that there is a left MC-M1 cutoff. Rest of the angio is normal. And now the consent was taken, the lab was normal, the patient was lies with TNK 0.25 mg per kg, and then immediately the patient was shifted for CT angio to see whether there was a recanalization or whether the patient needs any kind of intervention or not. So the CT angio done immediately after the IV thrombolysis, after some time, maybe 10-15 minutes, and here we can see that the CT angio is showing recanalization. Okay, there's a complete recanalization of the left MC, we can see that. Okay, and here also we can see that this is the CT angio image and this is the prior MR angio image. We can see the complete recanalization of the left MC. Here is the video of the patient. I had taken the consent of the patient, and now the patient, the power was which was grade 0 in lower limb and grade 1 or 2 in upper limb, and now the right side she's having complete good power. Okay, so this is the case of basically large vessel occlusion, which was complete being recanalized by IV tenecteplase and good recovery after that of left hemispherical infarct. So now after that the patient is completely all right. Now the workup was not significant, the echo was also normal. And I would like to present second case of similar this thing, large vessel occlusion. Here is a 50-year-old male who had hypertension and diabetes, admitted with left hemiparesis. Now here the symptom of onset was around 10:30 a.m. and now the patient came in ER around 2 p.m. So it was slightly just out of window, 4.5 hours. Okay, the patient had NHS of 12. The power in the left upper limb was around 2/5. Okay, the MRI was done. The MRI was the perfusion images here.
Sorry to interrupt. You said
Yes,
10:30 p.m. and patient came at 2 p.m.
sorry, sir, it's AM. Sorry, it's my mistake. So it's
yeah. Okay.
So in the morning he had symptom and he came to at around 2 p.m. So it was around 4.5 hours. So this is the perfusion images. The perfusion images showed that there is still a lot of area other than the core area. So the MR angio was done. The MR angio was showing that there is right MCA cut off completely. The patient was lysed with tenecteplase, and the post lysis there was remarkable improvement. At the discharge the NHS was 7. So this much size of infarct he had developed at the time of discharge, and the MR angio also showed complete recanalization. Okay, so these two cases I wanted to show for basically good results of tenecteplase in case of large vessel occlusion like M1 right as well as left MCM.
Dr. Ichapuria, would you want to discuss?
Yeah, Vishal, this first CT angio, no, first case, CT
Yes, sir.
angio, just show that again,
Mhm.
please. Yeah. You know, actually,
Hmm.
I'm not convinced that it's totally recanalized. There are good collaterals. Uh,
Hmm.
but if you see here, if you see M1, there is a cutoff. It's
Hmm.
not going straight on.
So this image which I'm
No,
pointing here
the below one, CT angio.
is yes. So
Yeah.
here I can see, yeah.
So these are the collaterals which are seen, and
No, so this is the main vessel. This is the MCA which got
yeah, I
recanalized.
know
These are
it's
not
the
good.
MCA,
Yeah.
but
Yeah.
if you see the trunk of the MCA, you compare it
Mm-hmm.
on the left side, on the right side, and the left side.
Yes. Yes. Yes.
There is a distinct difference.
So actually, can I also add, sir?
Yeah.
I also felt that one important point which we may have to see is that when we do an MR TOF image, most of the time in the TOF image, it may be very difficult to, it may even look like an occlusion. So in a situation like which there is a short thrombus or a partially occlusive kind of a thrombus, if you do an MR TOF image, it may look at occlusion. The other one is a CT angiogram. You're clearly getting the picture, wherein it may be a partially occlusive thrombus, or it may even be a underlying ICAD is possible, seeing the pattern of the infarct, which is showing a pattern of scattered infarcts which are seen, which may be a occlusion with an underlying ICAD is possible. So whether the recovery was completely related to, because here it is not completely recanalized. There is a
No, it's not
Maybe
completely
partially
recanalized. There
recanalized.
are
Yeah.
collaterals, but the collaterals,
Possible.
if you compare on the right side and left side, they're not going right up to the periphery.
yes.
So, it's not fully collateralized. It's, I would say, 80% collateralized. And
Imaging difference is also a factor. So many
yeah,
times.
yeah, of course. So, I don't know. I don't follow this protocol, of doing a MR angio and then following it up with a CT angio. Why not do a CT angio straight away? So do a CT scan. Patient is within window. You do a NIHSS is high. You do a plain CT scan followed by, and if there's no bleed, you give thrombolysis and then do a CT angio.
So we
That
actually follow
saves
the same
time.
protocol.
Huh?
We actually follow the same protocol, but this patient was referred by physician after doing MRI. So
Okay.
Yeah. I think now we need to educate the physicians that you have to call a code stroke in the hospital. This was in a large hospital. So it cannot be an individual physician's opinion. It has to be protocolized, and
right.
in the hospital, that protocol has to be followed. So, if each individual does his own thing, then it becomes a little difficult for, to deliver good quality stroke care. Now, I'm talking frankly, don't misunderstand.
No,
But
perfect.
this is what I think we should do, because we have to protocolize, and we have to, in that same hospital, everyone has to follow it. Everyone has to be on the same page. If one person does one thing and the other person does the other thing, then it doesn't, the effect is not so good. So I would urge you that, you sit down with all your physicians and your ER people and protocolize this thing. Exactly what are you going to do? Patient comes to ER. Are you going to do CT? Are you going to do CT angio? Are you going to thrombolize? Are you going to do MR? Are you going to do MR angio? So, protocolize this properly so that we can deliver more effective and sustained and, uniform stroke care. Now you are
Right.
working in a large hospital, much, much larger than what we are working in. So you have to get all those 10, 15 physicians on board and do it in this proper way. What do you say, Dr. Padma, Dr. Shailaja, Jayanta?
Yeah, just a
Yeah,
quick.
yeah, totally
Yes,
agree.
I
Totally
totally
agree with that.
yes.
You need to, and I guess that accreditation actually comes in place only because there are protocols in place and there is a chain which is well oiled and running, and you what you say is a sustainability. So then you can scale it up because those two are deeply important verticals on which you do when you make a stroke chain. Totally agree with that. Even your second case, Vishal, the imaging has a little problem in that. I think even in your second case, the first imaging which you have shown, I see an infarct there on the right side. Go back to the first one. Yeah. Here, the right side. Now that is an infarct. That's, you see here below. Whatever, because I can't point it out. Whether I can,
Yeah, that
this
appears
part.
to be
This
an
is an
old
infarct.
infarct. Huh?
That's an infarct there. And so, and then, final image, we don't see this. So I'm not, see this whole thing. This is an infarct here. So we can't discard this. And when you show it, your final image, you've shown a final image. See, this is the whole thing is infarct here. There is an old thing sitting there. So
Yeah,
it's
this
not
is the
just
old stroke. Yes, this is the old stroke.
there is an infarct here. So we can't discount this part of it and say that he's only left with this little area. Not very sure. And then this old infarct, the vessel couldn't have just opened up. I don't know. Even here you've shown that there is a complete opening of the image. This is also rather hard to buy.
Yeah. But anyway, the point that I think Vishal was trying to make is that tenecteplase is good for LVOs.
Open, yeah.
Yeah.
Which
So,
is
that point is very important because, many interventionists are going straight for MT. Now, as Subhash has already said, that, our protocol is to give IVT followed by MT. And I wish all the interventionists follow this protocol because a good 30-40% of them improve with IVT. And you're saving tremendous amount of resources in our country or in any country for that matter. So going straight for MT, I think is bad practice. I'm sorry to use
no, but there is actually now enough scientific evidence to say that bridging is the thing.
So and somehow we are finding that tenecteplase is wonderful. I would use that word for opening up LVOs. And umpteen cases on this forum we have seen umpteen cases that M1 occlusion have opened up with tenecteplase. So I think, the data has not shown it up to now, but the feeling that we get is that tenecteplase is superior to alteplase for LVO also. Now, all the trials which have been done have shown non-inferiority, but the trial has not been geared or this thing to show superiority. So maybe the next trial, if we gear it up to show superiority, I am certain in my mind that it's going to be superior, because I've seen umpteen cases of LVOs opening up with TNK. I don't know what is the experience of other people. I would like to know.
I think from TNK, even I fully agree with you, sir. We have also
I think that's
cases, yes.
That is right. Yeah.
Yeah,
so
Subhash,
I think
what do
for
you
want
feel?
of time, let's quickly go to the last case. Can we finish off the last case?
Yeah. Okay.
Hello. Can we just Dr. Chapuria, because it's past 10.
Yes, of course.
Can we do the last case,
Of course.
please?
This discussion can be endless.
Siddharth?
So we'll have to cut it short.
Yes, ma'am, I'm here, but my video has been blocked actually. So the host can unblock my videos, then I can start, I think.
Yeah. Host, please. Are you listening?
One more example of large vessel occlusion, man.
Huh?
Blocking of the video. Large vessel occlusion.
Really, so appropriate. Host, where are you?
Sir, it cannot blocked by the host. You can just check your
Can you
camera.
see the
Yeah,
slides
we
now?
can. We can. Go ahead, please.
Uh,
Go ahead.
Okay, so good evening, everyone. I'm Dr. Siddharth Singh. I'm a neurologist at Sayatri Super Specialty Hospitals. I'm working in Dr. Ichapuria's team. So today I'm going to present a case of stroke in young. The patient was a 27-year-old male. He was on a two-wheeler in the morning and he was sitting with his friend when he felt sudden onset dizziness and he somehow stopped the vehicle, and when he was his friend got him up, he noticed that he was having left-sided hemiparesis. So he had come to the hospital at 11 a.m. That was within half an hour of the onset of symptoms. And we announced port stroke immediately, and initial assessment was done, and he was immediately shifted to CT scan. So at presentation, he had normal vitals. He had tachycardia, but blood pressure was normal, and he had mild tachypnea of RR of 24 per minute and temperature of 101. On history taking, he told that once in a while he was having fever in the last 1 month. On neurological examination, he was awake, alert with mild dysarthria, and left upper limb was 0 and lower limb was 3 by 5, and NIHS was 11. So immediately he was taken for the imaging, and CT aspects was good. He had come within half an hour, but as we can see on the angiogram on the right side, the middle cerebral artery was not visualized beyond the M1 segment. So, but there was partial flow across the thrombus. So it was a partially occluding thrombus, but it was a large vessel occlusion with good within half an hour, and patient was having a moderately large stroke by NIHS. So we were planning what to do next. However, when we were taking the other cuts, we also noticed that there was a free floating thrombus sort of sitting in the proximal ICA on the affected side, and on
Just
the
show
right
it.
side. Yes. Here. So this was in the proximal ICA, as we can see here. The pointer is around the thrombus. So the free floating thrombus was there along with a large vessel occlusion. So while we were taking the arch of aorta cuts, and we also noticed that the lung was involved. And as you can see, there are bilateral consolidations, especially in the upper lobe. And we also ran a perfusion study as part of the protocol, and that showed us a small infarct of around core was around 13 centimeter cube, whereas hypoperfusion was 2.36 times larger. That was around 31 centimeter cube. So this was an excellent case for revascularization, but the question was how to proceed next. So just to summarize, what was the other thing than the large vessel occlusion was a 13 millimeter partially occluding thrombus in the right IC origin, and there was cavity along with consolidation, and multiple nodes were seen, and mild splenomegaly and mildly dilated left ventricle of the heart. So considering that he came with a high grade fever with young stroke without any other history which would suggest any other risk factors, what would we prefer to do next? Would we go for a thrombolysis only, or would we go for direct to cath suit and go for direct MT, or would we bridge with thrombolysis and mechanical thrombectomy, or would we treat him just conservatively? So this was the dilemma we had, and considering the high grade fever and possibility of infective uh, endocarditis or any other infective source, we have decided to take him for mechanical thrombectomy. So this was the clot in the proximal ICA, which we have taken out, and when we hooked the artery, and then only we've moved up, and in the intracranial you can see that there was a M1 partially it was flowing through. So there was a thrombus, but it was partially filling defect, and we have removed the whole clot, which was slightly friable, and as you can see, it was red with other the angiogram showing that the M1 segment was now recanalized with good TK2B to 2C flow. And although it seemed to be a slightly thinner lumen than the other side, but it was a good flow and the collaterals were well seen. So the groin puncture to recanalization time was 35 minutes, and door to recanalization time was around 1 hour 10 minutes. So it was done pretty fast with the adapt technique, and the patient was immediately shifted to the ICU, neuro ICU, for further care. On the initial labs on the first day, we found that the slightly elevated homocysteine, ESR, CRP, and D dimer was also slightly elevated. 2D echo we had done in a screening 2D echo I had done in the casualty, but then we got it done by the cardiology department detailed echo, which did not show any clot or vegetation. We had planned to do further investigations, but we had also sent specific tests from the mechanical thrombectomy, which we will discuss, which would make this case much more interesting on what we found. So patient was ventilated and later on he underwent bronchoscopy, and bowel aspiration and lung biopsy was done when the reports were sent. And after the procedure, he had improved and NIHS had reduced to 4. So the bronchoscopy showed bilateral consolidation in the upper and right middle lobe. And so we had sent the histopath for the thrombus from the mechanical thrombectomy from the cath lab. And surprisingly, the histopath also showed AFB in the Nielsen staining. And the histopath report, which was a detailed report which came from the pathology department, showed that there was septic embolus with numerous acid-fast bacilli within the thrombus material, which we had retrieved from the penumbra. And it was correlating with the lung biopsy, which was showing acute and chronic granulomatous active TB with gene Nelson stain, and TB PCR also showing, gene expert was showing Mycobacterium tuberculosis. So what was the final diagnosis? So it was a pulmonary tuberculosis case causing septic embolism and leading to acute ischemic stroke with LVO, and he underwent mechanical thrombectomy with good outcome. So this was a septic emboli. So we have given him an antibiotic initially, and then anti-tubercular drug was started. At the time of discharge, he was walking on his own. Minimal support was required, and he just had left upper limb drift and mild ataxia. So he had a MRS of 2 at discharge. And as we know that stroke in TB, commonly we see with vasculitis, with TB meningitis, and it can be inflammatory, like how we were seeing in other infections, or platelet activation and aggregation, thrombocytosis. They have also have a case report in which a patient with cavitatory lesion, and he coughed so severely that he had a embolus of massive air embolus, and they had, but probably this is the first case in which we have found, there's no reported case as such which has found tubercle bacilli in the thrombus per se. So this was something very unique which we have found. So the other, we already know about the other infection and strokes, like direct invasion of the arterial wall and endotheliopathy, or acceleration of the atherosclerotic process, or as a stroke trigger by the acute systemic infection, as we saw in COVID-19 and other influenzas, or could be due to the chronic inflammation as seen in periodontal infections. So we had a good residual flow grade was also good in our patient. That means that there was a good connection between the distal flow and the proximal flow. The thrombus was not occluding it completely. We could see a line connecting the two. So that was one more learning point, that such patients, when we recanalize, they generally do well. So what did the literature show? That there was this by Yadav et al., this microbial signature. So they've done something very similar, that they had sent anyone who was undergoing mechanical thrombectomy for bacterial analysis, and they found staph, lactobacillus, and multiple other things. So what they have seen is that multiple mechanisms can be in play. But these are generally things which are accelerating probably the atherogenic process, or probably as part of the clot. But in ours, it was probably a huge embolus of the bacteria itself, and then forming a clot there. Probably it went into the pulmonary circulation and went ahead. We wanted to see for a PFO, but because he was an open case of TB, we didn't do the TE. But probably, maybe the pulmonary circulation directly into the left atrium and then the left ventricle, and from there also could be one possibility in our case. So the Chinese have also studied. They have even found Acinetobacter, which shows poor MRS, and then they have found Bacillus. Then they have found many other bacteria which are there in our microbiome. So it might be a good practice to send histopath and culture for all our thrombus aspiration materials. So finally, this is the flowchart of what we can do with LVO stroke patients. So the thrombus should be sent for sequencing, bacteria culture, fish, and then we should compare it with multiple other sites like blood culture and see if there is any correlation if the bacteria is found somewhere else. So I think that was our case, and we really learned something from this patient because we found Mycobacterium TB in the embolic.
Dr. Call?
Yeah, I know this case. I think it's a great case, very, very eye-opener. And I think we have also learned a lot from this case. Very unusual, but very thought-provoking.
Absolutely. I think it's an excellent case and very well presented. Very well presented. An excellent case. So any final comments from the panelists, the course directors, about any points that you need to emphasize, especially in the eve of the end of the 75th, the anniversary of this great show? Starting from Dr. Call, take home.
Sir, one doubt from Dr. Achipuria, sir.
Yeah, go ahead.
Sir, what made you think of this and not go for IV thrombolysis directly, sir? Just curious. Half an hour he came knowing you would have just shot the bullet. Why you didn't do in this case, sir?
Yeah, but you see, SMS, when we did the CT angio, we found those cavitatory lesions in the lung. And also he gave a history of fever off and on for the last 1 month.
He came with fever too.
Yeah, he came, he was febrile also. So we thought that it is a septic embolus at that time only. And therefore we said, oh, if it is a septic embolus, he may be having something else also. At that time, we didn't know that it was TB. So therefore we went in for direct mechanical thrombectomy. This is exactly at variance which I mentioned 10 minutes ago. So 10 minutes ago, I said that we should not do direct empty. But if it is an infection, an SB, bacterial endocarditis, then IVT is contraindicated.
Yeah.
Sir, I would also like to add that most of the infective endocarditis cases which have been reported also where the bleed has happened, most of the time it was never diagnosed. Only retrospectively this episodes of on and off fever was there. So that's one point which we may always have to think about when we are thinking about IV thrombolysis.
And he was a young man, no risk factors.
Yes.
Yeah, no risk factors. And so if you are suspecting septic embolus, then don't do IV. That is the only one little thing, because otherwise we would do IVT followed by empty. Khalas. It's a protocol. There's no discussion on that. But in this particular case, because of this peculiar situation, we did direct empty first.
Yeah. How did it occur to you to look for acid phos bacillus in that, sir? That was awesome.
that was a brainwave, So we said, no, all these clots we must send. So then we sent the clot to the histopath. And then suddenly in the OPD, we were just discussing. I said, why not do AFB stain in this clot? Because we found AFBs in the bronchoscopy. So I phoned up the pathologist. And he said, sir, how can we ever see AFB in a clot? I said, but Mihir, his name is Mihir Vaidya. So I told him, Mihir, just do AFB stain, no? Just do it for my stupidity. So then half an hour later, he phoned up all excited, sir, I found AFBs in that clot, and I'm putting it for culture. And he sent those pictures to us. So we were also very, very thrilled to see all those AFBs in the clot, and literally it was teeming with AFBs.
Did you send it to NEJM as the picture? You should.
Now we are in the process of writing it, and Padma, we are not from an academic institution, so
neither am I. Now.
So we are having great difficulty in writing it up and all, but we are writing it. We are writing it, and I think we should publish it.
No, you could send the picture, the clot with AFB as a picture.
I think we should do
to
that.
NEJM.
Yeah, I think we should do that. Yeah. Because it's quite unique and I don't think it's been reported. And I think now all of y'all, when you'll see these clots, just send them here. Just see whether how much fibrin is there, how much RBC is there. Just put it for culture. You never know what you'll find.
Yeah.
You never know what you'll find. So that's it.
So over to the course directors.
Subhash?
So the message is that just do it whenever you have an acute stroke. Just do it, but don't do it mechanically, right? Don't do intravenous thrombolysis mechanically. You should also think about it as you thought about this particular patient. From my experience, I know for sure some patients who were thrombolized, they actually didn't have an infarct, they had a hemorrhage. But we will not talk about it in open forums because those were missed. You know, sometimes in acute diffusion weighted images, the infarct looks just like a hemorrhage. They all look hyperintense, and people did not look at GRE carefully, and they were thrombolized, and many of them did well actually even after that. So, but it should not be done. So therefore, always do intravenous thrombolysis, but before you shoot it, look carefully at the entire profile of the patient. In some of them, it may be contraindicated. Yeah.
Right. And I think in our stroke practice, there are certain things when they come with a stroke and either fever or hypotension, there's something is wrong. So the thing sends us signals. Something is amiss. So look for it.
Yeah.
So I think it's almost 10:30. Can we pass on the proceedings to the host if all agree?
Yeah.
Yes, thank you, ma'am. So I would like to, on behalf of Emcure, I would like to thank all the faculty members, our course directors, our moderators, faculty members, panelists, and importantly, speakers who have presented so nice cases. And this was one of the most engaging discussions for no thrombosis. We would all agree. As Prashant already said, this was one of the most successful no thrombosis series with more than 1,000 logins, the online as well as the physical attendees. So we are thankful to all the faculty members who made it possible and had excellent knowledge sharing to all our audience as well as within the faculty members. So on behalf of Emcure, I would like to really extend a thank to all the faculty members, speakers, moderators, as well as our audience for patiently listening and having this marathon session of no thrombosis. And I think this is a most successful session. Thank you so much, everyone, and have a great good night. Thank you.
Thank you. Good night. Bye-bye.
Thank you.
1,000 people is quite a record.
Good night, doctors. Good night, all.
Good night.
Good night.
Thank you.
Good night.
Bye.
Good night, everyone. Thank you.
Recording stopped.